address treatment, evidence-based treatment, which is CBT. And CBT is a buzzword, so everyone is using it. It doesn't mean they're doing the right treatment. So just be aware if somebody comes into your practice and says, I had CBT, it just didn't work, I need to try something else, make sure you ask, what did you actually do? Very often it's just talk therapy, and they're not doing proper CBT. Just that people now know they're supposed to be doing CBT. Okay, I'd like to acknowledge my research assistants who who are always very helpful in putting the presentations together, doing the lit search, helping with our drug studies, and the various research projects that we have ongoing at Biobehavioral at all times. So thank you. All right, so what are the effective treatments? Exposure and response prevention, and we'll go into detail for each one of these categories. Cognitive therapy. We do not have time to go into adjunctive therapies, which are acceptance commitment therapy, dialectical behavioral therapy, compassion-focused therapy, and family interventions. Those I don't think I will have time to go into, but you should just be aware that those are used in conjunction with ERP and cognitive therapy, but are not your primary treatments. So what do we do prior to starting our treatment? So you have someone sitting there, they've told you all the subtypes or whatever is bothering them, and you have this information, you've determined that they have OCD, now what do? Well, really to understand what their daily life is like. How does it interfere with their functioning? How much anxiety, distress do they feel in the various situations? You could do a typical day for that. So start off with, you wake up one time, 7 a.m., okay? Do you have difficulty getting out of bed? Because right there, they may have to have some ritual in order to even start their day. So you want to know. Okay, then what do? Can you get out of bed? Do you have to, they may not want to touch the floor. So you go step by step, go slowly, because they'll just report to you, well, I get up and then I go and get dressed and then I have breakfast and then I just watch TV all day. Well, that gave you zero information. So that is not going to help you develop an anxiety hierarchy or to determine what treatment you're going to use and how you're going to use it. So go very slowly, detailed. Okay, so can you step out of bed? All right, where do you go from there? Well, I go into the bathroom, okay? Do you encounter any problems in the bathroom? How do you open the faucet? How do you use any towels or paper towels? Go understand every single step. They may not be able to prepare breakfast. They'll tell you they ate breakfast. Okay, but who prepared them breakfast? Okay, they're preparing breakfast. How are they preparing breakfast? Can they actually open the refrigerator door and get milk out of there? Where are they going to put that milk? So it's really very detailed, and you'd be surprised at every single step of the way they could run into a problem. Maybe their child or husband, before going to school or work, left the cabinet open for them to actually get that glass out of there. Maybe they opened the refrigerator door, but then they had to wash their hands in order to close the refrigerator door, and then wash their hands again in order to get a piece of toast. So go through each particular step. Are they able to put on their dress or their pants? Because they may not want that touching the floor. How did they put on the shoes? Did they clean the shoes before? Was it said in a special compartment of clean clothes, clean shoes? So unless you determine all the different levels, it's going to be hard for you to determine what you're going to target. Once you do that, assess for suicidality. OCD people are usually not suicidal. So in OCD, I'm not particularly concerned about suicide. If they are BDD, you assess it every session, every single day, because they are suicidal and they will commit suicide. So your BDD patient, your body dysmorphic disorder patient, is going to be very different than your OCD patient. But still, look at suicidality. Sonny mentioned the Y-box checklist. It does exist for children as well. That was a question, which is the CY box, the child version of the Y box. There's also a body dysmorphic disorder version and a hoarding version. Y box is not a diagnostic tool. It only assesses severity. How many hours are you obsessing? Is there a block of time where you're not obsessing? How long is that? Does it interfere? How much does it interfere with your life? How much distress does it cause? Are you able to resist? Doesn't mean you have control. How much effort do you put to resisting? And how much control do you have? We do that for the obsessions, and we do that for the compulsions, and we get a composite score. Our 11th question has to do with insight. Are you aware that your symptoms are due to OCD? And as been pointed out by Megan and Sonny, they usually have very good insight. Unlike our related disorders, where usually the insight is poor. Overvalued ideation scale is a scale that we developed at Biobehavioral Institute many, many years ago. It is a great prognostic indicator. You can get the scale. I'll give it to Tyler, and you could request it from Tyler. Or you can look it up. I think it was a Behavior Therapy and Research Journal in 1996. It has been found in many, many studies, both for CBT as well as medication, interestingly enough, as a great prognostic indicator of treatment outcome. BDI's depression scale, bank depression, bank anxiety. Eureka looks at readiness for change. Is your client pre-contemplative, contemplative? Are they going to engage in your treatment or not? And then quality of life scale, which is something that we firmly believe at Biobehavioral Institute, and that is, it's not enough to reduce symptoms. You have to, after you reduce symptoms, work on the quality of life of the individual. But first, get the symptoms reduced. Marital therapy, lots of people come in for therapy. They have OCD. My belief is don't touch the marital issues. Work on the OCD and tell the couple, until your OCD is more or less okay, we don't know if you have a marital issue or not. I mean, you might have developed a marital issue as a consequence of your OCD, but it might disappear. Now, I had family intervention, or you'll see it. Family intervention is very different than family therapy or marital therapy. Family intervention refers to research done in the area of accommodation versus antagonism. Accommodation are families who are doing everything in their belief that they're helping the patient, the client, but in reality, they're only prolonging the symptoms. They're doing the rituals for the individual. They're trying to justify it, neutralize it, normalize it, none of which is effective. On the other hand, you have families that are totally antagonistic, hostile towards their loved ones. They can't stand the OCD, and they're negative, and they put the person down. That doesn't help either. That only prolongs the symptoms, just like accommodation. by making the person have to repeat the rituals and get depressed, more anxious, stressed out they are, the more they're going to do their rituals.
Question. How long does that review typical take? I mean, it lasts if you're doing the pre-taking assessment because you're going through every.
Well, if you get into if you could think like an OCD person, I mean, and at this point I think like an OCD person. So for me, it's 15 minutes or so,
okay.
you know. But you know, you just have to know because most of them hit the same roadblocks. You know, getting out of bed, touching the floor, repeating behaviors, brushing their teeth over and over again, not putting their clothes on perfectly, just not having the just right feeling. If it's contamination, you know. If it's checking the stoves, you know. So you kind of know what the symptoms are. There's a Y-box checklist, I have it up there. That is perfect because if you just have them do that immediately, they'll know what their symptoms are.
Right. But like as you were saying, okay, how do you get out of that? You know, if I don't touch the floor yet, go to the bed, you know, like now you're up to breakfast and then you still got to touch you after breakfast. That's a lot.
It's over. Yeah. It'll go faster and faster.
Oh, okay. That's interesting.
No, it's not going to take you, but okay. So you're now beginning. So you have to look for prognostic indicators. One I already mentioned, which is your overvalued ideation. How well is this patient going to do in treatment? Does this patient need weekly sessions, 3 times a week? Does this need intensive outpatient care? Does it need a residential program? Does it need inpatient hospitalization? Should we refer them over to Tyler Newport Academy? You have to make that determination. Don't just assume you're going to see the person weekly and that's going to be great. So you look at your prognostic indicators. How severely depressed is this person? Are they going to engage in ERP? Okay. How strongly are they convinced that their belief is correct? Something that Megan and Sonny touched upon. For the most, yes, they have very good insight. And OCD individuals compared to the related disorders have excellent insight. But if you're dealing with related disorders, usually it's poor insight. And we do have a percentage of OCD patients that have poor insight. But insight is only one variable of overvalued ideation. Overvalued ideation looks at the conviction. How strongly do you believe that if you don't wash your hands, that you're going to get AIDS? How reasonable is this belief? How accurate is this belief? Do other people in your community believe this? If they don't, why don't the other people believe in it? What do you attribute this thought to? That's the insight. What do you attribute this thought to is your insight question, which is it's due to OCD. It's due to a psychological problem. But as I said, that's only one variable among all the other variables assessing overvalued ideation. There's a whole body of literature. I won't get into it because this is my passion. I strongly believe in overvalued ideation as a predictor, but also something that we need to target before our treatment if they have high overvalued ideas. So you want to look at that. Do they have personality disorders? Would they benefit from DBT? Do they need other forms of interventions that are going to interfere with your treatment? What kind of support system can they get to you? Are the family members supportive? Not accommodating, not antagonistic, but supportive. That's important. Are they functioning? Are they in school? Are they going to work, or are they homebound? Are they dating, or your relationships going okay? Are they socializing, or they've kind of withdrawn more and more? So functionality. And then what are the treatment interfering behaviors? Are they calling in late? they've made a consult appointment but did not show up. They keep telling you why your treatment isn't going to work and that they've already done this. So you want to look at the treatment interfering behaviors. And if they've done other behaviors, as I said, was it successful, was it not, and did they actually do the proper, appropriate treatment? You have to determine during that consult visit the treatment frequency. And there are some guidelines in determining that treatment frequency, how often they're seen, how many hours a day. And that is based on prognostic indicators as well as whether they have been successful in other treatments, how often were they seen in those treatments previously. So you might have someone who's been seen 2-3 times a week for 1 hour. And then usually the therapist will say, this isn't working, maybe you need something more intensive. So functionality, other times they're doing okay, but they needed more quick response. They have to get to school by September. We're now in June. We have 3 months to get them back to college. So that's somebody who needs an intensive program. Others who are about to lose their job, school refusal due to OCD, usually will need more intensive. Flexibility. You have to go out of your office. A lot of therapists like staying in their office. But then there are those who really like going out of the office. It gives you something to do. You're outside, or you're going to a mall, or you're eating at a restaurant. You go where the problem is. You may have to go to actually their homes, to their school. It doesn't matter where it is, you need to get out there. Lots of therapists do ERP by just giving them homework assignments. Okay, so you had a chat for an hour, and at the end of the chat, you say, okay, what I want you to do is this week go and touch doorknobs. Next week, the person comes in and says, I touched some. Well, good job, you touched some, all right, that's great. Meanwhile, you didn't observe how they touched that doorknob, right? They touched that doorknob by going like this, or they went like this and then they opened it with their elbow. You didn't observe that. You also didn't observe how they opened the door here versus the bathroom door versus the public bathroom door in Macy's, let's say for us, or the entrance into Macy's, or into a fitting room, etc. So by observation and by doing things with them, you model, and in real time, you can direct them differently. You have to look at what treatment has not worked, okay? So if it hasn't worked, it's very important to determine, so you don't do the same thing. There's no need to keep repeating the same thing. Be innovative, be creative, find other ways to get to it. See where are the loopholes. Why didn't they get to where they should be? What went wrong? Just don't assume that they're not motivated or they just didn't do what they were told. Could be, but I always assume that somehow there is a reason, and as a detective, you've got to find that reason. And open your minds to every possibility. Okay, we got to engage those people in treatment. The engagement for OCD, again, is not usually too difficult. Occasionally you get some individuals who don't want to be there, but engagement is important if you have related disorders. They don't want to be in your office. And today we're not talking about those. We're talking about OCD. But in OCD engagement, you have to look at If they're not ready, why are they not ready? Is it because they really do believe it very strongly? Their anxiety is just so high. Have you determined a goal that is agreeable between you and the individual? So you have to kind of make sure that they are going to adhere to the treatment. And so you want to look at adherence session after session. That's the best predictor of outcome, because if they're not adhering, it's not going to work. But if they're not adhering, find out why they're not adhering. Maybe they need something else. It's not always because, it's a secondary gain. So let's not assume, because as therapists, that's what we are taught. If the patient isn't improving and is not doing what you told them to do, there's a secondary gain. They don't want to improve because if they improve, then they don't have to go to school, or they don't have to work, or they have to stay in the marriage, or they're going to lose their husband or what. Could be, but not necessarily. Not necessarily. Most often it's not. They just may need something else. And what is that something else? We're going to see. Exposure techniques are set up basically an anxiety hierarchy. You'll see it helps you if you set up an anxiety hierarchy. And you do that from that typical day, because you saw where they ran into problems, and those are the situations you ask them. If you had to do it the opposite way, how much anxiety would you feel? Right? If your pants touched the floor and you actually wore that pair of pants, how much anxiety would you feel? How much anxiety would you feel if you didn't balance both sides of your pants? How much anxiety would you feel if you walked out of your house? You're the first one to walk out of the house. You're the last person to walk out of the house. How much anxiety would you feel without checking the stove? By that, you develop an anxiety hierarchy. So next slide. This is just one anxiety hierarchy for an aggressive obsession, where the individual is having lots of concerns, anxiety about harming their parents. So what would you do if you had to put this in real life? Well, you could go to Home Depot and walk around where they have axes. You can pick up an axe and walk with the patient. You could have them bring in a knife and have them put it on you. Obviously, you have to trust the patient. You have to make sure there were resourceful here.
Interactions.
So, and you have to prevent them from avoiding. Avoidance is really important. Don't look only at the rituals, but also at the avoidance behaviors. Cognitive therapy. Most of the research shows that we don't really need cognitive therapy along with ERP. However, having said that, cognitive therapy, again, is extremely important for related disorders. Cognitive therapy can be utilized along with your ERP. If you are doing good ERP, actually, you're utilizing cognitive therapy along with ERP. But there was a struggle between the behaviors and the cognitivists for many, many years. The cognitivists said you don't need to do ERP. Well, that turned out not to be correct, because in cognitive therapy, if you don't do the behavioral experiments, if you don't actually go out and test your hypothesis, you don't get change. Okay? So you can't just sit there and talk about things and talk about, whether you get AIDS or you don't get AIDS if you touch something red. Okay? you need to actually, under many different circumstances and situations, do exposure and prevent the ritual of washing. So, in cognitive therapy, and most therapies, it's the exposure component that is actually bringing the change. The behavior therapist, prior to doing cognitive therapy, always said your anxiety will go up and there's a cognitive shift at the height of your anxiety, and then your anxiety will come down. That cognitive shift is where the beliefs change, which you could do through cognitive therapy in preparation for that cognitive shift, or it'll happen spontaneously. But if you don't do exposures, you're not going to get that change. What we usually target, and for those of us who participate in the obsessive-compulsive cognitions working group for many, many years, came up, we developed actually a questionnaire called the OCCWG questionnaire, and in that questionnaire is basically a whole bunch of questions, and the subtypes that we came up with: inflated sense of responsibility, overestimation of threat, the perfectionism, the need for certainty, the overimportance of thoughts, and the need to control thoughts. Those are actually what we are targeting in cognitive therapy, no matter what method we use. Basically, we're trying to decrease that inflated sense of responsibility. And most of you probably are working on the need for certainty, right? That you have to say, bring on the uncertainty, and deal and live with uncertainty. These are some of the studies. There's many, many studies to support that IOP, the intensive outpatient programs or more intensive programs, are much more effective than your weekly sessions. But in real life, we know that that's not possible for most therapists, many facilities. So you have to kind of determine whether you're going to be effective. And for many people who are functioning relatively well, weekly is fine. There's nothing wrong with weekly sessions. But that's, as OCD grows and it kind of snowballs if untreated, you need intensive for those individuals who are not functioning. New directions in CBT. We have the Bergen 4-day in Norway, in Bergen, Norway. There was the development of this 4-day treatment program. Right now in the United States, I think it's available in California. It's a 1 or 2 year training program to be able to do it. If you look at the program, it's basically doing marathons. That's what we always did. A marathon that we do is a weekend where we go in with the patient, and we just did one with somebody here. You're there from the moment they wake up to the time they go to bed, and you're there while they're basically sleeping, and you're there before they wake up. So you do that to hit every single OCD symptom during that long period. And you repeat that for, a few weeks. I don't know how the 4-day treatment efficacy is long-term. We don't have research on that yet. And radically open DBT, most of us know DBT, but for our OCD patients, often to deal with the rigidity, to deal with that need for sameness and ritualizations, poor social skills, radically open DBT is quite effective, just another form of DBT. Here are some treatment outcome studies just showing that it's effective, and that when studies have looked at ERP plus medications, ERP alone is better than medications alone. Medications alone, most medications to be considered efficacious, is only a 30% response. So always you have to combine medications with ERP. If CBT fails, and sometimes it does, we have 25% of patients who are treatment resistant. They do not respond to our treatment forms. I believe we haven't yet come up with the strategies to deal with those patients. So for the current time being, we have, of course, medications with or without CBT. We have neurotherapeutics, or non-invasive forms of treatment, TMS, usually about 36 sessions of TMS. We have repetitive TMS, which means prolonged TMS during the session. TMS, generally it can range up to 10 minutes, but repetitive TMS is about 30 minutes. So it's much longer sessions, sometimes up to 30. Up to 60. fMRI guided TMS, where you look at, don't forget in TMS, where this coil is put in your head, and they're trying to target the correct brain circuitries. And in that, they can't always get it correct. So that's why some patients don't respond. fMRI guided ones will allow you to be more precise as to where you're going to target because you've already had an fMRI. Deep brain stimulation, which is still non-invasive, but I would say quite invasive, where you have a remote control with actually electrodes put into the brain and you control certain areas of the brain. Magnetic resonance guided focus ultrasound capsulotomy is just now in March approved, and basically it's a capsulotomy but using ultrasound. So it's using brain waves to change the area in your brains that are related to OCD. We do have bilateral capsulotomy surgeries for OCD, which shows you how severe OCD can be. We have gamma knife surgery. We also have ketamine, psilocybin, and glutamine modulating medications. I think that's my last. Let me just say.
That's your last slide.
Types of referrals for DBS. You can take a look at yourself, but these are people who have not responded to TMS, CBT, ketamine, psilocybin, and all of them. You may then want to consider DBS. That's it.
Okay.